Welcome to the Cincinnati Children's Hospital Heritage Video Series. These videos are a project of the Medical Staff Historical Committee. I'm Dr. Elaine Billmeyer, a member of the Historical Committee. With me is Bea Katz. She's a longtime member of the Marketing and Communications Department. She's also the author of a photo history of Cincinnati Children's that was published on the occasion of its 125th anniversary. So our topic today is the ongoing history of the Department of Radiology. We have with us today two longtime faculty members. They're both emeritus professors of radiology at UC. We have Dr. Diane Babcock and Dr. Oestreich. So welcome, thanks for coming. Let's start off the stage and let you give us your little thumbnail biographies. Tell us how you happened to come to Cincinnati Children's and why you stayed so long.
Well, I'm actually a native Cincinnatian. I was born in Wyoming, which is one of the northern suburbs, and grew up there. My father was a physician and internist, and my mother was a stay-at-home mother. I guess I followed my father. He actually, in the 1950s, he took his daughters to work with him, to the office to see what it was like. And I worked in the summertime in his office, as did my sister, as secretary assistants, and I even did EKGs. Ah. Yes. So then I guess I decided early that I wanted to go to medical school and sort of father figure. And it's interesting looking back that in the 50s and early 60s, there weren't very many women in medicine, like 3 out of 100 in a class. But my family was never negative about it. If I wanted to go to medical school, I would go to medical school. They would see to it that it would happen. So I went to Cornell University, undergraduate as pre-med, and then went to Northwestern University in Chicago for medical school. And then I came back to Cincinnati to the General Hospital as an intern in internal medicine. Yes, so as an intern, we did a rotation through radiology. I was going to become an internist at that point, but rotated through radiology and really liked radiology. And Dr. Felsen and Dr. Wyatt were here at the time, and Moskowitz, and they were very encouraging to me to go into radiology. So I switched and applied for the radiology residency here and was able to get in at the last moment because it was the Vietnam War era, and one of the men was drafted, and I got his position as a radiology resident. And then I got to Children's because as a resident radiology, we rotated there for a couple months to peds. And again, I liked the environment and I liked the people. Dr. Silverman was there, and Corning Benton, and they had fellows that it was a family, and I found that pediatric radiology was really interesting. The anomalies, the bone anomalies were important at that time, but I like to work with the pediatric people, that they generally are nice people and caring. Of course. Yes. And so at that point, I decided I wanted to do more pediatric radiology. I never did a complete fellowship, though. So I went to Chicago because my husband wanted to do a urology residency up there. Right. So I did private practice at a community hospital, Evanston. And they had me doing the pediatrics and adult, so I did both. Okay. And then it was there, this is now 1975 or so, ultrasound became available as an imaging modality. And the group there wanted somebody to learn ultrasound, so they sent me for a week course to Yale, a whole week wow. to learn how to do ultrasound in adults. So that was my training in ultrasound. And then a little bit later, at 78, Dr. Benton contacted me. We had been in contact, but he contacted me and said, why don't you apply for the position here in Cincinnati, because the Children's Hospital needs somebody to take over the section of ultrasound. And I thought, well, that would be perfect, because my two loves are pediatrics and ultrasound. So I came and interviewed with Dr. Scott Dunbar, who was the chief at that time, and I ended up coming to Cincinnati Children's.
All right, excellent.
Yeah.
All right. And we'll get back to talk about all the ultrasound stuff in a minute, but we'll let Alan chime in and tell us your origin, his story.
Well, I'll start with women in medicine. My mom was a radiologist, and she and my dad, who's also was a radiologist, graduated the University of Vienna about 1932 and then came back to the United States. She had been an X-ray technologist before that and then moved over into medicine. So I first met Dr. Ben Felsen in 1946 when he bounced me on his knee. So he was visiting Buffalo where we lived. He was a war buddy of my dad's, both radiologists in the Army. And so that's when I first met him. I met Dr. Silverman. The most recent memory I have of first meeting him is when I was a resident in radiology in Rochester, New York, and Dr. Silverman spoke in Rochester and was going to Buffalo, New York, about 60 miles down the road, to speak at the Radiologic Society. And so I drove him, and we chatted on the way, and I asked him, well, do you think I should consider an academic career or a private practice? And he very strongly suggested an academic career in radiology, which I've pursued and continue to pursue.
Good advice.
When it came time to get out of the Army, Vietnam War era, I spent my time in Louisiana. And when I got out of the Army and came back, I accepted a position as a pediatrics radiologist in Columbia, Missouri, University of Missouri, first pediatric radiologist there. And when I started in there in about 1972, I took a week off to come to Cincinnati and see what was happening, to meet Dr. Silverman again. But Dr. Silverman was away in Poland, and so Corning Benton and others entertained me. That's where I began to learn about the department. And then when I was done with Missouri, it had enough of them in 1979, so I came here as a pediatric radiologist, a general pediatric radiologist. And no, I didn't know much about ultrasound, but we had Diane here. But my interest then and now is in plain image. We called it then plain film imaging, and that I still do. I'd say one thing about coming to Cincinnati is that Missouri is in the Midwest, and it was a friendly place. But when I came here, it was much, much more friendly. People were really helpful and nice here, and they still are.
Good, excellent, excellent.
So in the Heritage video series, we have some interviews with Dr. Silverman, particularly one where he talks about some of the other people he worked with in those early years. So what we were hoping is that you could set the stage for where the hospital and the radiology department was when you guys arrived. So 1978, 1980, what was the department like at the time? How large was the department? Who was here? What kind of imaging modalities were available?
Well, in 1978, Dr. Silverman had left and gone to California. He'd retired. And Dr. Scott Dunbar was here as the chief. He came from Canada and was very supportive of ultrasound. What we had was radiography and fluoroscopy and nuclear medicine, and ultrasound was just starting, basically a starting modality. And I took over, let's see, from Gary LeCain, Dr. Gary LeCain, who was from Australia, had started the ultrasound. Yes, and I was recruited to take his place because he was going to go back, and it was supposed to be a year overlap. So I came, and he got a position offered to him in about a month, and he went off to Australia after 1 month. But he had managed to train 2 excellent technologists. So there, let's see, Corning Benton was here. I'm trying to think who else. There were probably maybe 5 radiologists, small. And it was film-based. And it's interesting, I was thinking, we communicated with the clinicians orally. Not digitally, orally. And so every day the ward teams would come down, and we'd make ward rounds, and we'd go over the films with them and talk about each case. And everything was much slower paced. You know, the ED was not covered by radiologists at night. We got called in and the surgeon, I remember Dr. Lester Martin, the chairman of surgery at the time, had a patient with an intussusception, and I was at home on call, but I came in to do the reduction, and the surgeon, Dr. Martin, the chairman, was there with me doing it, and we communicated right away, and he took the patient wherever. But you know, the ward teams and the neonatologists came down. They still do come down and review their
own film.
Their cases. But then we dictate the report. So we have the case, and we dictate the report, and it would be transcribed by transcriptionists. So that would be the next day we'd get the report back to sign off. Okay. Then after we signed it off, it would be put in an envelope and mailed to the doctor who requested the exam. So the reports, you know, 2 days, 2+ days was the normal turnaround time for reports.
That's so quaint.
But much better than some other institutions.
Oh yeah, we were faster than
2 to 3 days. So
Yeah.
we were, when I
So you
came,
could,
and when Diane came, we were in the basement. We had the old radiology department in the basement. Nuclear medicine was kind of off to the side, but Mike joined us a few years later formally. And we had view boxes.
Alternators.
Yes, and we
4/4.
Yeah, and we looked, and indeed the interpersonal contact with all the wonderful people here was very nice. We trained people, we taught them things, they taught us things. It was a nice interchange.
So you had plain films, you had fluoroscopy, ultrasound. When did
Special procedures. Special procedures.
We did have some.
Neuroradiology special procedures with Corning Benton. The machine was one in which, to look inside the brain, air was put in, or oily material was put into the spine.
Pneumoencephalogram.
The patients were inverted. It was quite an uncomfortable feeling for the children. And
they were asleep. They were put to sleep.
Yes, and the diagnoses were made, but then CT really made the difference. CT and came on board, and
I'm trying to remember, was there a CT here for maybe a short time, and we had to send the kids across?
For a while we had to go across the street. Then we got our own CT, and then came magnetic resonance, and we got our own magnetic resonance, and special procedures became a specialty, and a lot of things got done through the years.
We had angiography at the even back when I was training, but it was. It was very difficult in children with small vessels, and they had to develop special catheters. But Corning Benton did some angiography, and then the neuro people did it. But it was all very invasive, and those procedures wouldn't show the brain tissue. They would show maybe the ventricles or the vessels, and so you'd look for displacement. Secondary displacement to infer that there was a mass there or the ventricle was enlarged. So you really weren't seeing the brain until CT came along. And they had the first scanner, EMI scanner here at General Hospital. That was
right, EMI.
EMI. It was in the mid-70s after I trained. So it was like 75 or so. And our patients had to be transported in an ambulance over here, and some of them were sometimes not so easily. And one of the reasons we started doing head ultrasounds was because we didn't have a CT scanner, and people said, oh, you can't look at the brain because you can't scan through the bone. Well, some people in Australia and Europe realized you could. You just go through the fontanelle, and they were starting to do that, like in Australia, which is how Dr. LeCain knew to do it, and he started doing it here. Yes, and so we started doing head ultrasounds. The patients had to be brought down to the department, but that was easier than bringing them over to General Hospital.
Right.
And we could actually see inside the head and see the brain tissue and the ventricles. And Dr. McLaurin and the neurosurgery and the neonatologists really were supportive of ultrasound because that was the first time they could see into the brain.
It was the first time they even knew what was going on.
Right.
Yeah, yeah.
Right.
So let's keep going a little more about ultrasound. So the head ultrasound, that was one of the big developments, and then what were some of the other?
Well, even before that, we started doing ultrasound of the abdomen, kidneys, kidneys and especially with the renal problems in children, liver, spleens. So pelvis, we were doing abdominal work as the adults had been doing. Just different techniques, and we had to get the patients to hold still. So we had nurses to help us with that. It was before child life. But we had nurses, and we actually gave them chloral hydrate babies because they had to hold still for like an hour.
But as an alternative to such medications, we also had a nurse who sang to the babies. And very often she knew what
Very
to
often
do.
that worked.
That worked.
And we gave them, we had
funny.
them held NPO for 4 hours, and then we fed them on the table with the heater hanging over, so they got warm and they got their bellies filled, and they got somebody singing to them, and then they'd fall asleep long enough that you could do a scan, but the scans did take a long time to do.
So you're developing innovative techniques as you go. It's a new field.
Yes. Well, there are a few hospitals in the United States that were doing ultrasound on children, you know, the big children's hospitals. But none of them really had started on the brain before we did here. So that's, I think Cincinnati was at the forefront of that.
Cincinnati was a...
And that was sort of the beginning of your going around lecturing at meetings and visiting professorships and really spreading the word and doing a lot of the early fundamental work when you were at one time a one-person department. And a few of us came along to try to help out after we had, but you were...
Well, for several years I was the faculty, and then Dr. Kim Han was a fellow, and then she became faculty, so then we had two. And yes, and then I was going around lecturing and teaching to other children's hospitals and to technologists how to do this what it would, and that you can do it. And so that was really fun. And the technologists we had here were really wonderful, and I have to give them a lot of credit for developing the technique and being patient and getting pretty pictures. They're very proud of their pictures.
That's good.
So I know radiology is an incredibly technical field, and the technology keeps advancing. Can you give us a little sense of the growth of the new modalities as they came online?
Right. So I am not a new modalities person.
I know you're not.
I have learned some of them. But radiology, back in Dr. Silverman's day, it was basically the black and white images with fluoroscopy and some of the others. And it was first supplemented with computed tomography and magnetic resonance imaging and these modalities. And part of what we do here was to learn from the CT and the MRI to go back to what we need to see on the plain images. And so through the years, I have championed plain images. Every radiologist does them, but the excitement is in the big things. So I try to go against the excitement and do what is necessary for a lot of primary care of children, and we still do it. We encourage the new people coming in to understand and look for the plain image findings, and it's still there.
And
But
still, yeah.
And worldwide, the plain films are still important.
worldwide,
And
they're important,
ultrasound,
but
too.
ultrasound is, in Europe and other places, ultrasound even supersedes plain films for a lot of the things.
Interesting.
They've developed
Yeah.
small handheld transducers that hook up to a laptop.
Oh,
So,
of course.
so you can go third world countries. You need electricity, or you have solar powered
Oh,
equipment, and so yeah, they
But
actually
it's more economical
some of our
in
younger,
that sense.
well, radiology equipment
Yeah.
and the films and all
Yeah.
is relatively expensive and
yeah.
breaks down. So
And then somebody has to fix it.
some of our
and-
younger
yeah.
younger colleagues go on missions various parts of the world, and they take a little ultrasound machine with them.
They do things, yes.
Yes.
Interesting, yes. Well, so speaking of plain films, so one of the things that you and I worked on way back when I was doing child abuse, was doing a lot of plain films, so, skeletal surveys.
So for
you
child
wanna-
abuse, we call our skeletal surveys for possible child abuse the Silverman survey, because Fred Silverman was one of the pioneers in discussing the radiology findings. Even before our time, people didn't believe in child abuse, but it was there, and it still is there. And so, yeah, with Meg Correa now, a pediatric neuroradiologist and child abuse physician, we weekly go over problem cases with the child abuse team, and daily we go over, I look at the x-rays every morning to see what's happened, and our people are pretty good at recognizing the subtle signs. But it's a twofold thing. One, we don't want to miss the possibility of child abuse. Two, we don't want to overdiagnose the child abuse. So a lot of what we do is working to be sure that we see it, and our colleagues see it, and then working to be sure that it's a real thing. But in the recent decade or so, a cloud has come across the child abuse in America because of the so-called denialists, the people who deny that something is abuse. They don't want children taken from the home under any circumstances. We want the children to be in a safe home. But as far as the findings of child abuse, some of the basic things Dr. Silverman and others have done, and they're still good.
And you're still doing pretty much the same techniques?
Yes, we do.
I don't know if there were other evaluations,
Yes,
obviously.
we do the head CT regularly.
CTs, right.
But yeah, we've added a few international groups of pediatric radiologists have added oblique views of the chest to see rib fractures better. And so it gets modified, but it's a real service for whoever can recognize unexpected fractures. And we hope to be able to keep teaching people how to do that.
Yes. Yeah, go ahead.
So a totally different kind of diagnosis. I know you were really instrumental in identifying the danger of magnets that children were ingesting, and that was something that was really big news. And
that was and is big news.
Yeah.
So
Tell
what
us about
happens?
that.
We had a patient come in who was an autistic boy of about 12, who at summer camp started vomiting a little bit after an arts and crafts thing that he was not supervised with, and he was a little uncomfortable. After a day or so, he was sent home, and the mother watched him for a few days. He had a little pain, not too bad. Then he came to the emergency room, and in the emergency room they took a plain image of his abdomen, and there were all these metallic things in the middle of the abdomen at a time when radiologists didn't really recognize that they were magnets. I had already just done a little review of articles out of England and the Far East about such cases, that it's dangerous, so we'll get to it. One magnet, fine. More than one magnet, especially beyond the stomach, can catch a loop of bowel and cause damage. Ischemia, loss of blood, holes in the bowel, bowel telescoping, many things, and then eventually the symptoms occur. So what happened is one of our good fellows saw the case in the afternoon and didn't know what was going on, so she went to one of our senior staff who didn't know what was going on, and the next day they showed the x-ray to me and said, what do you think? And since I had this article, I knew what they were thinking. And I said, basically I said, cut. Or refer quickly to the surgeons. And they went in and they found the magnets, unfortunately, in holes in the bowel and going around.
Oh, gee.
So it was the patient recovered after a lot of time. So far, we know only of 2 fatal cases, children who didn't get to medical attention soon enough when they had peritonitis or other problems from it. But it's a big problem, and as we discussed it locally in the newspaper and put it into our radiology journals, eventually I made the New York Times.
Well, there you are.
And were there changes in how toys are made, or no?
And Big Toy tried their best to avoid it. They said, oh, we're going to make things bigger, but kids were swallowing the bigger ones too.
Yeah.
So it's still a problem. And as usual, Big Toy, when the Buckyballs were taken off the market, they had their lawyers go to work and they got it back on the market. So it's still a very major problem, and I make sure that our elective medical students, when they come through, know about it, and most of them do know about it. And my wife, when she's taking a walk, if she sees somebody in a stroller, she gives them the story.
Well, there was one foreign body that we had an effect on, is pennies.
Okay.
Children
Tell us.
swallow pennies and they get stuck in their mid-esophagus. And at one time, they were going to take, what is the metal that you can see? It's not the copper.
Well, but
They
made nickel pennies.
Nickel, isn't it?
Yeah, and you couldn't see it on x-rays.
Right. So somebody wrote an article and complained, and so the government kept the metal in so you could see them on the x-ray. They were going to take the metal, the type of metal out so they wouldn't be visible.
Well, that's unusual that you would affect the whole treasury system.
Well, it was only pennies. But
It was only this.
meanwhile, Dr. O'Hara, who now runs ultrasound here,
Right.
she found that Coca-Cola and other acids in the stomach would erode pennies. This was later regular old pennies. And so she led to radiologists recognizing pennies that had erosions in them so that they could be removed before they caused even more trouble.
She wasn't recommending drinking Coca-Cola to dissolve the penny.
No, not at all.
Okay. All right. These are great stories. What are there some other firsts or at children's?
Hundreds of firsts.
Yes. Well,
Lots of
tell us about some of those. Yeah.
I was talking about Fred Reichman, the liver
yeah.
transplants and the ECMO patients, and he did them in animals first. Started with the ECMO, which extracorporeal membrane oxygenation, where they put the child basically on a lung bypass while the lungs recover from disease or diaphragmatic hernia. And when he started doing it here, I mean, it's an amazing procedure with lots of tubes and various things. And we were involved because he wanted head ultrasounds. We do them before they put them on, because if they've had a bleed in their head, 'cause you don't want to do this because they heparinise them. The circuit is heparinized so it doesn't clot.
Right. Okay.
So he always wanted a head ultrasound beforehand and determined that this was not good for premature infants because they are susceptible to bleeding till they're at least 32 weeks gestation. So preemies are excluded from ECMO because of potential hemorrhage. And the other ones, we do a head ultrasound, make sure they haven't had a hemorrhage before he'll put them on. And then when they're on, because of the heparin, we scan them regularly to make sure they haven't developed a hemorrhage. So, but working with him, I don't think we were the first center to do ECMO, but one of the first. And
it was a collaborative.
And speaking of animals, first I'll mention what Dr. Jan Valetsky, who was a fellow here, found a case of rickets in a monkey in the zoo. A young monkey had the metabolic disease that young children get when they don't get enough vitamin D and not enough sunshine. So
interesting.
But the real more recent story about the zoo, Diane will tell you about.
Well, I mean, Children's Hospital people have consulted with the zoo all along. The neonatologists took care of the baby gorillas, and I guess still do, over the another nursery, not ours, but
Yes.
anyway.
Yeah.
So we get consulted and asked to do various animals. And one time I did an upper GI on a baby gorilla, or an enema. The baby gorilla, the gorilla was having diarrhea, so they asked, the veterinarian called me and asked if we could do an enema. So I said, oh sure, we'll bring him over to the research lab or the animal lab, and we had a setup there to do it. So
Did you have somebody singing to the gorilla?
no,
to calm
that
him
would
down?
have helped.
Okay.
But we had the baby gorilla and holding the arms up and put the tube in the rectum, and you know the barium's starting to flow, and I'm fluoroscoping, and there's no barium. I can't see any barium. So I looked down at the patient, and we forgot. Their feet are prehensile. The gorilla had reached up and pulled the tube out. So we had to start over again and holding the feet. That's one of my favorite animals.
That's good. That's
but
good.
also, I was asked to ultrasound the walrus to see if she was pregnant, because it was they had not been able to get a baby walrus, and they had a breeding pair, and she'd had some miscarriages and all that. So, so we went over to the zoo. I got one of the companies to bring one of their big machines, and we rolled it down the track where the little train is, and they trained the walrus, the female, to get out of the water and come over and roll on her back up against the bars.
Oh, for heaven's
And because I didn't want to take the machine in there, so
Yeah,
she would come over, and as they were like feeding her or something to keep her occupied, she'd lay there, and we'd reach in and scan to see if we could find a baby. And indeed, we had to get special transducer that would go through all that, you know, subcutaneous blubber.
Yeah.
But we were able to get good enough images to see a little baby walrus and the heartbeat and everything.
Oh my,
And
that's exciting.
Dr. Lori Barr and I wrote a paper with the veterinarian. It was published.
What
A
fun.
pregnancy in a walrus.
That's great.
So through the years, we've added more and more and more very fine pediatric radiologists. We've had through the years 1 or 2 fellows who were suboptimal, but almost all our fellows have been wonderful, and many have stayed. So when I came, maybe I was the 6th person here.
Okay.
And then through the years comes a 7th, a 9th, a 12th, a 30th, a big group.
Yeah.
And many people stay for a long time,
Yes.
such as us.
Yeah. How many? How big is the?
I don't know.
or-
And the other thing, you have to think FTEs, because another wonderful thing that was done in Janet Strife when she was chairman and had children and knew the problems, she started allowing people to work less than full time. So we have people that work 3 days a week, 4 days a week. We have people that only work nights, only work night shifts.
Okay.
So I'd have to figure out FTEs, but I don't know. But
Full-term equivalents.
Yes.
Yeah.
Right. Yeah.
yes, it's got to be about 30.
We're in the
Yeah, 30.
mid-30s.
Yeah.
I think we're in
Yeah.
the mid-30s in terms of people, and this is not counting the Imaging Research Center, which has a lot of scientists working here with their own MRI and their own CT.
Do you know what they're working on?
Many things.
Anything?
Many things.
Anything
One
in
thing-
particular? Yeah.
One thing that's happened over the years, initially, the people that were radiologists like Silverman and Caffey were originally pediatricians,
Yes.
and then
Right.
subspecialized into radiology. But they were pretty much general radiologists. We were general radiologists for a long time, and then as the modalities evolved and diseases got more complicated, it seems like, the radiologists specialized in bone or GI or GU or neuro, and neuro is now really its own subspecialty, at least here. And also when we got different equipment, like people would specialize in MR or MR of the knee, and so it's changed, and we have special people that do research in the lab, and Dr. Bill Ball was the one that started that, the Imaging Research Center, IRC. What else do they specialize in? We have people
We have many
specialize in
things.
PACS.
Just about anything, yeah.
There are departments of pediatric radiology in which everybody does everything. There are departments of pediatric radiology where each person does his thing,
His or her,
and you hope you get coverage when he or she is gone. And
Uh-huh.
we are more like the Venn diagrams. Everybody
okay.
does maybe one specialty, but we also do other things.
So that you can
Yeah.
cover
Yes,
and,
so
and
everybody
collaborate. Yeah.
may cover this and that, and even the neuroradiologists, they also sometimes
Yeah.
cover other things.
Yeah.
And so
Is
it's
it-
very nice for training. Somebody goes away for a while,
Uh-huh.
then our trainees always have somebody to argue with.
Yeah.
So that was kind of a
something to
line
argue
of
with.
questions
Yeah,
that we were
yeah.
going to ask, that you've talked about the growth and the comprehensiveness of the program. That I know that our radiology department is considered one of the top, if not the top, pediatric radiology department in the country, and also a top training program for pediatric radiology. So we wanted you to talk a little bit about how that reputation grew and what significance it has. What does it mean in terms of the impact of the department?
So when it all started and when I was looking for things, there were only a few major centers with 2 or 3 or 4 radiologists, and some of them got a fellow every year and some got no fellow. The last solo fellow we had is now dean of the medical school for another 3 weeks. And,
Okay.
But now we have 8, 9 fellows who rotate through the various parts of the program. But our reputation, yes, has grown, and it's grown because we've done things. It's done because we go talk places.
Is it still just a fellowship in ped
It's
radiology,
a
or is it more?
It's
can
basically a
subspecialize?
fellowship. The
Yep.
first year is usually a general pediatric radiology
Uh-huh,
fellowship,
yeah, okay.
and then we have interventional radiology fellowship, we have neuroradiology fellowship,
Okay,
we have
okay.
potential musculoskeletal, potential ultrasound.
Okay. So all of those.
Depends how the job market is. People like to.
Yeah.
We're probably one of the top 3 training programs in,
Oh,
the
yes.
in,
At
the,
the-
in
at
North
the-
America.
At the very least.
Yeah. Yeah.
Yes. Yes.
And we get
Well-
international visitors, quite a few. Some
Yeah.
stay for a year, some stay for a day, some stay for a week.
Yeah. Yeah.
Some
And-
for
And both
A
of you, I was going to say, so when people come to us, both of you have been very active, not just locally, but nationally, internationally. Can you tell us?
Well, like the
about some
American
of that,
College
yeah.
of Radiology sets standards for doing procedures and things like that. And we are very involved in the national organizations that do things like that, and also the teaching.
Standards in
society.
terms of technical standards or indications for,
Both,
or all of
actually.
those?
Both.
Yeah.
So Dr. Silverman was one of the pioneer
Mhm.
pediatric radiologists in the United States who went regularly to the European Society for Pediatric Radiology, not to mention the Pediatric Radiology Society of America.
Yeah.
And I followed a little bit in his footsteps that way, and I've been to the international meetings a lot. Diane has been sometimes, and every year a few. This year, the meeting is in Berlin. I'm giving a lecture, and one of our fellows is giving a lecture. And sometimes we have more people there. And then the Society for Pediatric Radiology here in Nashville, where Diane visited. I'd say thousands of papers from our place. No,
Yes.
but dozens, certainly.
Are there any hot topics, or? I mean, they're all hot topics to you,
Artificial
but
intelligence.
in
Artificial-
radiology,
Yes. Teaching the computer to read
to
the
read
films
the
for us.
films.
Oh, really?
Yes, and they already have a program to do bone ages.
They have had to. I tried that once when I was in the Army,
Yeah.
and I didn't get very far, but now it's proceeded.
And they're working on like an application to when you have oncology patients, they get chest CTs regularly and looking for metastatic nodules.
Sure.
So on the follow-ups, you measure the nodules and the location of each nodule. So on the follow-ups, you have to measure the same thing and compare it if it's gotten bigger or smaller or
Sure.
whatever. So
Sure.
the next thing they want to get is the computer able to do
To
that.
do that, yeah.
Yes.
Yeah.
to
And
help.
it's controversial.
I was going to say, is there something to this, or?
Oh, I think there are definite applications.
It can do things. Another hot topic
Yeah.
in my field, in the child abuse thing, so a very specific small topic. At the meeting in Nashville, there were papers dealing with the shape of the very end of the long bone in young children who are at an age they might be abused. Is there periosteal reaction as a result of it or not? There are things. And what I'm talking about in Europe is the oblique X-rays looking for the ribs in the skeletal survey. I'm specializing in the acromion part of the scapula up here, how you can
Wow,
see
that's
that nicely. Yeah,
specialized.
that's quite specialist. But I'm a generalist. I'll do left or right. When I used to give an introductory lecture to the medical students on their first day, and just so that they could meet a real clinician type of stuff, I used to start off by saying I'm a healthcare person, I'm a physician, I'm a radiologist, and then I worked my way down saying my specialty is the proximal end of the second metacarpal, and they like that, and I said the left one.
Oh, golly.
One thing we should,
go
we
ahead.
haven't mentioned, we
Yes,
should,
go ahead.
radiation and radiation protection. And
Oh,
our
yes,
Image
yes.
Gently campaign that
Yeah, tell
started
us about
here
that,
at Cincinnati Children's.
It
Well,
started here.
Basically.
Sort of, yeah,
And
okay,
actually, when
yeah.
you go back,
Okay.
it was mentioned that Silverman did something about radiation, the effect on children. I mean, it's known that radiation does have some side effects, potentially hazardous side
sure.
effects, and that children with a growing body are more susceptible than adults.
Sure.
And I think when it really became an issue, we've always tried to narrow the beam down to as much as possible and have the dose as low as possible. And one reason ultrasound became so popular was because it's non-ionizing radiation,
Right.
and it can do a lot of things. But I guess when we were doing more and more CT, when CT came in, it was wonderful. 5-10 years after we started doing CT, we started realizing that the radiation doses were relatively high, and that we were using, in other places, were using more than necessary for a small body. They were like using an adult dose to get the picture. And so our department started looking into that and researching that and developed a national program called Image Gently. Marilyn Goski and Neil Johnson were involved, and our physicist, Strauss. So that everybody is now much more aware of radiation dose used, especially in CT, but other things. And we now measure the body part and have a chart to choose just the amount of radiation that the machine needs to use to get a good picture. So that was all developed here, and then it went nationally, American Academy of Pediatrics and everything. And then the adult people found out, oh yeah, maybe we're using
Maybe we should look at this
maybe we
too,
should look at
yeah.
this too, because small
they're big adults and little adults,
yes,
right,
yes. So
right.
now they call it Image Wisely.
All right.
So I found in the literature from Germany a little over 100 years ago a plea for imaging gently. So I think it was a pediatrician who noticed skin damage from X-rays in children, and he came up with the idea: don't image more than you have to. Limit the dose. So it was around, but it didn't catch on until this modern era.
Took a while, yeah.
Time of Rankin.
I was going to say, yeah, was it
One of
Rankin
Rankin's
himself?
associates.
Wasn't Röntgen himself.
So one of the other questions we wanted to ask, and you've mentioned working with Fred Reichman, and are there other collaborations, looking back over your years at Children's, other departments that you collaborated with on a regular basis? And
Lots.
Many, yes, many.
See, I was involved with collaboration with the neonatologists, Dr. Tsang and Dr. Koo, and we were dealing with metabolic bone disease in the premature or less premature.
Station with the hemorrhage.
Yeah. So,
Right.
but we've done a lot of things along with them, and we've worked along regularly in weekly conferences with the kidney people.
Yes, nephrologists and urologists.
And there's close contact to the chest people.
Yeah,
And
yeah.
certainly genetics. When Dr. Warkany was here, Dr. Silverman and Dr. Warkany and colleagues had a wonderful weekly conference trying to figure out what the strange things are. Now we have more fancy genetics, but we still, we are consulted as pediatric radiologists. What does the pattern fit? And often it does. And sometimes you have new things.
And is that typical of other institutions, or is there something special about the way collaboration happens at
We do
children's?
it better, but no, it's everywhere around.
Yes, we probably do it more, I think. And we used to do it more than we do now, because we don't have the interaction immediately with the clinicians, with the PACS system and everything digitized.
We have to do it by email.
Yeah.
But in child abuse, Dr. Correa and I regularly every week go to this child abuse meeting.
You go to the meeting,
Yes,
and
we do
discuss
so.
what's happening.
Yeah, that's great. That's great. Yeah. You've mentioned certainly Dr. Silverman, Corning Benton, some of your mentors. Are there other mentors that we should talk about, or colleagues?
Well, Dr. Brian Colley, our chairman now, is head of the editors of the main pediatric radiology textbook, and he and many others have been chairman of the Society for Pediatric Radiology, including the first African-American president of the Society for Pediatric Radiology, which was Dr. Lionel Young, who was taught by Fred Silverman and is still active out on the West Coast. We write a lot of us write a lot.
We've written a lot of articles. Several of the main pediatric radiology books have come out of this department. Caffey initially with Silverman, and then Don Kirks, who was chairman at the time, he came up with a major, and Bill Ball wrote a textbook on neuroradiology. So we've had a lot of effect on other people through that. And the other thing I have to say is, the first chairman were not trained here, but the last 3 or 4 have been. And my present boss was my fellow. And the present dean was my fellow. So, you know, all these people, you train them, and then pretty soon they rise up and they're your boss.
Well, that makes you feel good, though.
Yes.
You must have done something.
No, I feel very good about it.
Right.
I feel very good about it.
Good.
Yes.
Good. Are there other topics, other things we need to
Let me
add
see.
we haven't covered?
We didn't talk a whole lot about interventional. Interventional radiology, I want to talk about it. It started with Corning Benton doing the neuroradiology and angiograms and pneumoencephalograms and things like that for diagnosis. But more recently, well, in the last 15 years or so, radiology and radiologists have taken over doing treatment procedures. They're not only diagnostic radiologists, they're now therapeutic radiologists, and they tap and drain collections, they do bone biopsies, they do a lot of things that used to be, you had to go to the operating room and open up the patient, and now...
Or you just stab blindly and hope you hit the right...
Right. No, they actually...
It's guided imagery, is that the... I mean,
It's
you do it under...
Actually, they guide it with ultrasound, or they guide it with fluoroscopy, or they can even do CT guidance. And you know, the newer modalities are more difficult, but all these are potentially able to be used. And their interventional radiology suite is up on the 3rd floor next to surgery. So they are working with the surgeons and developing techniques. So they're sort of in between radiologists and surgeons, and that's actually it's a wonderful new field for anybody who wants to do hands-on procedures.
Through the years, we've had technologies that didn't last. There was a little interest in thermography, where we were measuring the heats of various parts of the body and trying to make diagnoses from them. One thing very useful that we gave up on after CT, which is cross-sectional imaging, we used to have plane tomography, where the machine and the film would move back and forth, and we could get a beautiful slice of one area of the body. And there still are times when we see x-rays and, oh, it would be nice if we could still do it. But they're not around anymore, at least not here. Maybe we could find some place that is backward, and then we could get the advantage of it. But 3D, we used to have the ability to take two x-rays next to each other, and then we had machines that we put the film in each side, we'd look and we'd get a three-dimensional image.
Like the old
And then, yeah, that was good. And then when that was on its way out, we were able to sit back and many of us could cross our eyes and get it in 3 dimensions. But that's gone away too. So we've had things that have come and gone.
Yeah, yeah.
And
But we can do 3D imaging now. We can, the computer, you
Right,
take
yeah.
the slices and then the computer
Right.
reconstructs
In
it in three
ultrasound, yeah,
dimensions.
Oh, yeah.
Ultrasound,
And
CT,
four-dimensional.
MR.
And
we can
Yeah.
do fourth-dimensional things.
Yeah,
Yes.
yeah, cool.
And some departments even do 3D printing, but we don't
yes.
we don't really do that.
We've
But
looked into
we
it.
do the
yeah.
scans and then
Yeah.
we have
I
we
think
have
the
a
imaging,
computer.
the research, the Imaging Research Center does
IRC.
that.
Well, we also have that the cardiology has. I know they do the heart things,
Oh, yeah, yeah,
Yeah.
yeah.
but we do some 3D stuff even now.
But
Are there other
again,
technologies
yeah,
on the horizon?
in the horizon, there are some, but no big thing other than the artificial
Well, we
intelligence.
finally got
Right.
contrast material for ultrasound approved. I did research 25 years ago.
Okay.
Bubbles. You have a solution with bubbles, but you had to stabilize the bubbles, and then you could inject it intravenously, and it would circulate, and it would enhance, like the liver or spleen,
Okay.
so you could see the defect where there was a laceration or a tumor. CT has had contrast material
Sure.
since the
Forever,
beginning,
yeah.
and you wouldn't do CTs with of the abdomen without it.
Right.
So ultrasound had it 25 years ago, and I did things in the animal lab, and it worked fine. And the FDA took that long to approve it.
25 years?
Yeah, because you were injecting bubbles, and there was concern
Oh,
that
bubbles.
you'd end up with strokes and things like that. And the companies did go through a couple different types that they were making,
Yeah.
but it finally did get approved by the FDA, and this year we started
Golly,
using
at long,
ultrasound
at
contrast
long
material.
last.
Yes.
Has that made a big, I mean, have you done it
Well,
enough to conclude it's made a
we've
big
done it
difference?
in some cases, and it does work. It's not necessary for everything.
Sure.
So in the meantime, though, the equipment, our equipment just keeps getting better and better. I mean, the companies and the engineers improve the images. Every year it's better. And one thing about this children's hospital, I have to say, I've stayed here because we've been supported with the newest, latest, best equipment. The radiology department has been very much supported, whereas other cities didn't have such well-funded hospitals and didn't have what we were able to have.
And I guess it's not just the equipment, but it's the person who maintains it
Sure.
and repairs it and
Exactly.
probably tinkers with it, I guess, at times. Do you have a whole crew of engineers? And,
We have,
Yes.
yes, and
With
then
you,
we
yeah.
contract out. I would just re-emphasize that the human body hasn't changed that much. The child's body hasn't changed that much through the years. And just
So that-
re-emphasizing that there are a lot of basics which get ignored in the excitement of the big
Of the-
machines
yeah.
that really we try to make sure that our folks come through and also learn that part.
Well, it's the anatomy, it's important to learn the anatomy and pathophysiology of every organ. So when a new modality comes along, you just recognize it's the same disease process as you saw before, but maybe you see it
Just
better
see it differently.
or a little
probably,
differently
yeah,
or without
yeah.
radiation. So you do need the basic anatomy and pathophysiology.
So we're pretty close to the end of our time. Would either of you like to reflect a little about looking back, what gives you the most satisfaction about your careers?
The people here are wonderful. We have almost always been supported in what we want to do. whether we're old-fashioned plain film people or fancy people doing the 5-dimensional MRIs. But it's a healthy place to work, and we hope we can continue having success with helping children.
Right. Excellent.
Yes, and I would say similar. I've had wonderful technologists to work with and wonderful associates, referring physicians. But Cincinnati is sort of unique in that we have one children's hospital here. I remember when there was a pediatric department or wing over at the general hospital.
Oh, yeah.
And then at 75, when the bond issue was passed, then that was closed. So it's all centralized in Children's Hospital. But and we have outreach facilities all around the city, and the neonatologists go to the other nurseries. And I think we're unique as far as that goes. When I go to other cities, their pediatrics is divided. So it's not quite as strong.
No, we as practitioners, we get lobbied sometimes by these standalone MRI, CT places, use ours, and it's like, it's not your equipment, it's who's reading it. You know, who's going to interpret it? That's why.
Well said.
That's why we have to go to you guys.
Yes. Yeah.
What are you both doing now? To keep busy.
They're still working.
Keep on trucking.
Keep on.
So I go over the child abuse x-rays every morning, or
Mm-hmm.
skeletal surveys, also looking for dysplasias. And I pop in the reading room and do pop-up teaching. I see something interesting, principles, and then I regularly myself do teach elective medical students and elective pediatric residents on a daily basis, and try to get the basic principles off to them, and something which is really important. We almost always mention magnets.
Yes. Oh, that's good. What about
Well,
you? Dan?
I do still come in and do some teaching. Medical students mostly that are rotating through radiology, and I find satisfaction in working with the young people, and they're there because they want to be there, you know, and they really appreciate any time you spend with them, because most people are so busy they don't get to. But I enjoy that. But the other thing is, as a visual person, I have become a docent at the Art Museum.
Oh, nice.
So
That's right. That's right, yeah.
5 years ago or so, I had waited for years to do it. And I went through a year of training. And I've always loved art and art history. And so I spend some time over there giving tours.
Excellent.
At our
And
weekly radiology surgery conference, it's clear that Diane, I try to do some of it too, asks pertinent general questions to focus on what's really happening. She's very good at that. And I'm going to try to do some of it too as we go along.
Oh, good. Great.
Yeah.
Well, thank you both. This has been fascinating. It's always,
It
isn't
always
it always
is, yes.
fascinating?
We
Thank
learned so
you.
much.
Yes,
Thank
yes.
you.
Thank you very much.
It's been fun.
All right.